I'm Dr. Steve Nissen, and I'm here with Dr. Ali Aminian, who is a bariatric surgeon at the Cleveland Clinic, although you like the term metabolic surgery, but we'll talk about that in just a minute. Dr. Aminian has just published a really impactful manuscript that looked at the long-term cardiovascular outcomes in patients with diabetes and severe obesity who underwent metabolic surgery compared with usual medical care. So let's talk about your study for a minute. How many people did you actually have that underwent metabolic surgery?
Thanks, Steve, for kind introduction. So we did this paper together, actually. So we had 2,300 patients who underwent these metabolic surgical procedures over a course of 20 years in the Cleveland Clinic.
Yes. And the procedures that you're talking about, so you like the term metabolic surgery. Maybe you can explain that to everybody.
So these procedures are called weight loss surgery or bariatric surgery or metabolic surgical procedures. We like metabolic term compared to the weight loss surgery because they have these procedures, these GI procedures have some metabolic effects beyond the weight loss. So that's why the metabolic surgery would be a better name for these procedures collectively.
Now, in previous collaborations between cardiovascular medicine and the bariatric surgical group, we had shown together that we could make diabetes better in people that underwent the surgery. They lose a lot of weight, their diabetes get better, many of them come off insulin. But you had a more ambitious goal. You wanted to look at broader endpoints. So let's talk about the endpoints you looked at.
As you correctly mentioned, Steve, we knew before this study, we knew that these procedures significantly cause weight loss, significantly improve diabetes, but we didn't know the impact of these procedures on hard cardiovascular endpoints.
Yes.
So that was the main goal of the study. So we enrolled 2,300 patients who underwent metabolic surgery, and we matched them to almost 11,000 patients who received usual care for their diabetes and obesity in the Cleveland Clinic, and we followed them up to 8 years after enrollment, and we studied the impact of metabolic surgery versus usual care on major cardiovascular endpoints.
Yeah. And as I recall, the endpoints there were 6 of them. Let's talk about what are the 6 endpoints you looked at?
So the primary endpoint of the study was a composite of 6 endpoints, including all-cause mortality, coronary artery events, cerebrovascular events, heart failure, kidney failure, nephropathy, and atrial fibrillation.
Was there a favorable effect in the group that underwent surgery on every endpoint?
That was favorable, striking effect for every single individual endpoints.
And they were all statistically significant?
Yes, significantly, hugely significant. So we observed almost 40% reduction in a primary composite endpoint, which was composite of all these 6 endpoints. And for every single individual, we observed significant reduction in these major adverse cardiovascular events.
What I found the most striking was the reduction in all-cause mortality. It was 41%.
41% reduction.
If you think about the treatments we have for cardiovascular disease, including the most successful treatments that we have, like statins, we don't get a 41% reduction in mortality when we're lucky to get any reduction in mortality. So that was pretty striking. Now, this was not a randomized controlled trial. This was an observational study, and I wonder if you could maybe comment on what you think the take-home implications are of a study like this.
So as you mentioned, the effect size was striking. 41% reduction in mortality or 40% reduction in the composite endpoint was impressive, but the limitation was that that was observational study. So we need to do randomized clinical trial to confirm these findings, but it's not easy to do randomized clinical trial. It's going to be very costly. It's going to take some time because we need to randomize 2,000, 3,000 patients to surgery versus the medical care, and then follow them for a long period of time to see this difference. So hopefully we're going to do that, but in the meantime, I think we can rely on the results of findings of this study and similar studies like this. And the take-home message would be actually few take-home message. One would be that these negative effects of obesity and diabetes on cardiovascular system would be reversible if we have a method for significant, sustained, and durable weight loss. We can prevent all these bad effects of diabetes and obesity on cardiovascular health. The second take-home message would be awareness for patients and the physicians. So I think primary care physicians, cardiologists, endocrinologists, if they have a patient with severe obesity and diabetes, should think about the bariatric surgery or metabolic surgery as a tool and should consider referral of those patients to the bariatric surgery for the assessment. Not all patients would be eligible, would be a good candidate, but at least they should consider that and they should start discussion of this option, this effective and safe treatment option with their patients. So these would be the take-home.
Now, a couple more issues. So to get into this 2,300 patient group, how obese did you need to be? What were the kind of the things that you had to have it actually be included here?
So we have criteria for that, but broadly, patients needs to be severely obese or need to be mildly obese, but have severe comorbid conditions and risk factors for cardiovascular problems. If the patient has BMI of 40, would be eligible, or a BMI of 30 to 35 with multiple risk factors would be eligible.
And so those would be. Now, of course, surgery has complications. Let's talk a little bit about what were the downsides, what were the things that people need to be aware of that are potential risks of the surgery.
Yeah, that's right. So every surgical intervention has some complications. So these days we do these procedures with minimally invasive surgery approach. We do surgery through 5 or 6 small holes, not the big cut. Surgery usually takes about 2 hours. Patient usually stay in hospital 1 or 2 nights, and recovery takes about 2 to 3 weeks. The risk of complications usually between 3 to 5% for all complications together: bleeding, infection, anesthesia problem, blood clot, heart attack, everything together. So which is very comparable to the commonly performed procedures like gallbladder surgery or appendectomy. So overall, these are very safe procedures and the recovery is quick.
And one of the things you tracked, interesting enough, is nutritional abnormalities. We always worry about that. You didn't turn up a lot of problems with the surgery.
That's right. So these procedures are good for patients who are compliant with the lifestyle change after the procedure. If we see a patient who's not compliant, that would be with the recommendations after surgery, that patient wouldn't be a good candidate. In our study, about 2% of patients had severe malnutrition in 8 years. So that's one factor. So I always tell my patients that the surgery is not a simple fix. We give you this tool, you need to use this tool to succeed. So you need to follow the recommendation, you need to watch your diet, you need to exercise. If you don't do these things, then you're gonna gain all the way back, and you're at risk for nutritional complications.
Now, can we talk just for a moment about the types of surgery that were included here? There's several types, and now this has evolved in recent years. So what do most of these people have?
So that's right. So it's evolving, and that's very good. So now that's why we have safer procedures and more effective procedures now. The 2 most common procedures in the study were either sleeve gastrectomy or gastric bypass. In sleeve gastrectomy, we As I mentioned, we go inside the abdomen through 5 or 6 small incisions, takes about an hour, and we excise about 80-85% of the stomach, and we take that part out. We do not reroute the gastrointestinal tract. In gastric bypass, again, through 5 or 6 small incisions, we go in, we cut the stomach on the upper part, we make a small pouch on the upper part of the stomach, and then we bring a loop of a small intestine up and connect to that pouch. So we reroute the GI tract. When patients take food, foods go through the esophagus to that small gastric pouch and then directly to the small intestine. So we bypass majority of the stomach and proximal part of the small intestine. So we reroute the GI tract.
So the duodenum is involved. And do you think there's any difference in the efficacy in terms of the improvement in outcomes? Did you find any evidence of that?
On this particular study, we didn't look at procedures and we didn't compare them head to head. But their previous studies have shown that gastric bypass is a bit more powerful tool in terms of weight loss and in terms of improvement of metabolic disease in the cost of a bit more complication rate. So sleeve, overall, both procedures are very safe. Both procedures are very effective. Sleeve is a bit safer. Gastric bypass is a bit more effective.
Yeah. So look, let's just summarize here a little bit. Obviously, a study that's a landmark study published in a very prominent journal, JAMA, which is widely read. I think you've shown pretty clearly that these metabolic surgical procedures can not only make diabetes better, but can dramatically, really substantially reduce the risk of major cardiovascular complications and death in these severely obese patients. And you know, I think it's a game changer. I think we got to now think about this more commonly. And you know, we hope all of you will find this discussion interesting. I certainly found this to be an interesting collaboration, and we're very pleased to have been able to report this together.
Thank you very much.